Firstly, head to medsynclimited.com and get the Plastic Surgery Board Exam Revision Anki Deck with over 7,000 questions arranged by topic, covering every topic of the plastic surgery curriculum. This will turn passive reading and revision into active recall, based on the textbook Keynotes in Plastic Surgery. It is the go-to companion exam question guide. This is a chapter summary episode.
Okay, let's unpack this massive topic, starting right at the beginning with embryology. How do the branchial arches translate into the specific head and neck structures tested on the boards?
Right. Well, to really grasp this, we have to look at a 4-week-old embryo. At this stage, you have these paired outpouching swellings along the sides of the developing pharynx.
Like little gills almost.
Exactly like gills. I mean, the term branchial actually comes from the Greek word for gills, which, gives you a hint about our evolutionary history. We start with 6 of these paired arches.
Okay, 6.
Yeah, but, and this is a critical high-yield fact for anyone listening and preparing for the exam, the 5th arch disappears entirely. It just leaves no trace. Wait, it just vanishes completely?
Completely. Poof, gone. So every single remaining arch functions as like a self-contained developmental unit. You can think of each arch as a prepackaged delivery sent to a specific construction site in the head and neck.
Okay, I like that analogy. So what's in the package?
Every single package contains 4 essential components. You've got a cartilage bar to provide structure, a specific cranial nerve to wire it up, an aortic arch for the blood supply, and a core of myoblasts.
And those are the precursor cells for the muscle, right?
Exactly. They differentiate into the muscle tissue.
I want to stop you there because that delivery package analogy is really crucial. It's essentially a biological assembly line where specific nerves arrive precisely with their designated muscle packages. But the trick on the boards is that the cartilage doesn't always end up being the final bony structure, does it? Let's take the first branchial arch, the mandibular arch.
Yeah, that is actually the most common trap examiner set. So the first branchial arch comes with the trigeminal nerve, right? And it's applied by the maxillary artery. And its structural bar is Meckel's cartilage.
Meckel's cartilage, got it.
Right. And it gives rise to both the mandibular and maxillary prominences. Now, the logical assumption, and what most people guess, is that Meckel's cartilage just ossifies and turns directly into the mandible.
Which makes sense, logically.
It does, but it doesn't happen that way. The vast majority of Meckel's cartilage actually resorbs. It just acts purely as a temporary scaffolding.
Oh, wow. So where does the actual jawbone come from?
The actual bone of the mandible, so the body and the ramus that forms through intramembranous ossification from the dermal mesenchyme that just sort of sits immediately adjacent to that cartilage.
That's wild. So it just uses the cartilage as a guide.
Exactly. The only physical remnants of Meckel's cartilage that actually survive into adulthood are 2 tiny structures. You got the malleus bone in the middle ear and the sphenomandibular ligament.
So if you're holding a jawbone in an anatomy lab, you are not holding Meckel's cartilage. You're basically holding the bone that grew around its ghost.
That is a perfect way to put it, yeah.
And because that first arch is wired by the trigeminal nerve, what does that actually mean for the muscle package?
Well, it dictates everything. Because the trigeminal nerve, specifically, the mandibular branch, V3, because that is the nerve of the first arch, the mesenchyme from this arch forms all the muscles that the trigeminal nerve supplies.
So you don't even really have to memorize a random list of muscles.
No, not at all. You just have to think about function. The first arch gives us the muscles of mastication. So the masseter, temporalis, medial and lateral pterygoids.
Basically the chewing muscles.
Right. And it also gives us the anterior belly of the digastric, the mylohyoid, the tensor villi palatini, and the tensor tympani. They all share that exact same trigeminal origin.
Okay, so if the first arch is for chewing, the second branchial arch, the hyoid arch, is for expression, how does its delivery package differ?
So the second arch is supplied by the facial nerve, the 7th cranial nerve. Its vascular supply is the stapedial artery, and its structural bar is Reichert's cartilage.
Reichert's, right. Is there an easy way to remember what that one does?
Definitely. For the exam, you can just rely on the S mnemonic to remember what Reichert's cartilage forms. So think S. The stapes bone in the middle ear, the styloid process of the temporal bone, the stylohyoid ligament, and the lesser cornu of the hyoid bone.
Wow, that S trick is super helpful.
Saves a lot of headaches, for sure. And following the exact same logic as the first arch, the myoblasts here become the muscles innervated by the facial nerve.
So that's all the facial expression muscles?
Yeah, all of them.
Yeah.
From the frontalis way up top down to the platysma in the neck, plus the posterior belly of exactly one muscle, the digastric and the stapedius and the stylohyoid.
Wait, let me clarify something that always causes confusion. I mean, at least for me. We've talked about the lower face, the jaw, the cheeks. But what about the upper face? What about, like, the forehead and the nose? The front nasal process is often lumped in with this, but that's not a branchial arch, is it?
No, it is absolutely not. And the boards will definitely test your knowledge of that exact distinction. The front nasal process develops completely independently of the branchial arches.
Okay, so where does it come from?
It forms from a proliferation of mesoderm that sits directly ventral to the developing forebrain. So as it develops, it forms two localized thickenings of ectoderm on its lower outer edges. We call these the nasal placodes.
So I'm picturing like a horseshoe shape forming on the developing face.
Yes, that's exactly it. So the tissue on the inside of the horseshoe is the medial nasal process, and the tissue on the outside of the horseshoe is the lateral nasal process.
And what's in the middle?
The empty space right in the middle is the nasal pit, which, eventually deepens to become the nasal cavity and the actual nostril.
Okay, so the merging of these specific processes is really what builds the center of the human face. Walk me through the exact structures they form, because this is where the anatomy translates directly to the pathology we see in the operating room.
Right. So the medial nasal processes are the really critical players here. When the two medial nasal processes merge in the exact midline, they form the entire central column of the face.
Meaning the philtrum and all that.
Exactly. They create the philtrum of the upper lip, the cupid's bow, the columella, the nasal tip, the primary nasal septum, and the premaxilla.
And just to clarify, the premaxilla is that wedge of bone that holds the front teeth, right?
Yes, the wedge housing the four central incisors. Meanwhile, the lateral nasal processes, they form the nasal alae, which are basically the fleshy sides of the nostrils.
Got it. And if we understand that normal fusion, the abnormal pathology suddenly makes complete sense, right? Like if these tissues fail to fuse, we get clefts.
That is the exact direct embryological consequence, yeah. A cleft lip is fundamentally just a failure of fusion.
So how does a unilateral cleft happen?
Well, if the medial nasal process on one side fails to meet and fuse with the advancing maxillary process, which, remember, comes from the first branchial arch, you get a unilateral cleft lip. The tissue just literally didn't bridge the gap.
And bilateral is just that happening on both sides.
Exactly. And if the two medial nasal processes themselves fail to fuse together in the absolute center, you end up with a median cleft lip. In the Tessier classification system, we call that a Tessier zero cleft.
Okay, before we jump into the surgical repair of those clefts, there's a cluster of developmental terminology that acts as sort of a gatekeeper for these exams. You have to be able to distinguish between a malformation, a deformation, a disruption, and a sequence. Let's define the fundamental differences. Let's start with malformation versus deformation.
Sure. So a malformation is a primary intrinsic error in tissue formation. The genetic blueprint itself was flawed right from the beginning.
So the tissue basically never had a chance to form normally.
Right. A cleft lip or a cleft palate is a classic malformation. The programming just failed. Now, a deformation is entirely different. In a deformation, the underlying genetic blueprint is completely perfect.
Wait, if the blueprint is perfect, what goes wrong?
The tissue was developing normally, but an extrinsic mechanical force intervened. Some kind of physical pressure altered the shape.
So, like, if a fetus is developing in an environment with oligohydramnios, severely low amniotic fluid, there isn't enough fluid to cushion them. So the uterine wall physically presses against the growing skull or the limbs.
Precisely. That extrinsic compression causes things like positional plagiocephaly, where the skull is physically flattened, or congenital clubfoot, where the foot is forced into this abnormal posture.
But since the blueprint is fine, can it be fixed easily?
Often, yes. If you remove the force early enough, the tissue has the capacity to return to normal, exactly because that blueprint is still intact.
Okay, so malformation is an internal software error. Deformation is external hardware pressure. Where does a disruption fit in?
A disruption occurs when a destructive event tears apart tissue that was, up until that exact moment, developing perfectly normally.
So it's not a genetic flaw or just molding?
No, it's destructive. The classic clinical example is amniotic band syndrome. Fibrous bands of the amniotic sac peel away, wrap around a developing limb like a tourniquet, and physically amputate the fingers or toes. It wasn't a genetic error, and it wasn't just external molding. It was a destructive interruption of normal growth.
Man, that's brutal. Okay, that leaves us with a sequence. And this is where examiners really want to see if you understand causality, right? Because a sequence is basically a domino effect.
Exactly. It is a cascade of secondary and tertiary defects that all originate from one single primary structural anomaly. The primary defect forces the surrounding anatomy into abnormal positions, and then that causes the next defect.
And a Pierre-Robin sequence is the undisputed textbook example you need to know for this. Break down the dominoes for us. What falls first?
The very first domino to fall in Pierre-Robin is mandibular hypoplasia. So the lower jaw just fails to grow to an adequate size early in gestation.
And because the jaw is small, what happens to the tongue?
Well, because the mandibles is too small, there is literally no physical room in the floor of the mouth for the developing tongue. So the tongue is forced upward and backward into the pharyngeal space. We call that backward displacement glossoptosis. That is the secondary defect.
And the tongue sitting high up in that space, it acts like a physical roadblock, right?
Yes, exactly. Normally, the palatal shells start off positioned vertically, right alongside the tongue. As the embryo grows, the jaw expands, the tongue drops down, and the palatal shelves rotate horizontally to fuse in the midline.
Which forms the roof of the mouth.
Right. But in Pierre-Robin, because the tongue is trapped high up by that small jaw, it physically blocks those palatal shells from rotating. They just cannot fuse.
So you get a cleft palate?
Yes, specifically a U-shaped cleft palate. The cleft palate wasn't a primary failure of the palatal tissue itself. It was a tertiary consequence of the jaw just being too small.
That makes so much sense when you trace it back.
Right.
Okay, now that we've set the embryological stage, let's explore clefts in the actual clinical setting. The board examiners are going to expect a total mastery of this topic from you. How do we draw the anatomical line between a cleft lip and a cleft palate?
The geographic center of the palate is the incisive foramen. That is your absolute dividing line. Anything anterior to the incisive foramen is considered the primary palate.
So that includes what exactly?
It includes the upper lip, the alveolus or the gum line, and the small triangular wedge of the hard palate just behind the front teeth. A defect anywhere in there is a cleft lip, with or without alveolar involvement.
And posterior to that line?
Anything posterior to the incisive foramen is the secondary palate. This includes the vast majority of the hard palate and the entire soft palate, all the way back to the uvula. A defect here is a cleft palate.
Let's talk numbers and associations. What are the epidemiological facts you absolutely must have committed to memory for the boards?
Well, in the UK, the incidence of cleft lip, with or without a cleft palate, is roughly 1 in 700 live births. And it is overwhelmingly more common in males.
But isolated cleft palate is different, right?
Yes. Isolated cleft palate, meaning the lip is perfectly intact, but there is a hole in the roof of the mouth that is a distinct embryological entity. Its etiology is different, and it's actually twice as common in females.
Okay, clinical scenario. If a patient presents with a cleft lip, our immediate instinct should be to look at their lower lip and their dentition. Why is that?
Because you are actively looking for van der Waals syndrome? This is the most common syndromic cause of cleft lip and palate.
What are the signs?
It's an autosomal dominant condition, which is obviously vital for genetic counseling, but its clinical hallmarks are these distinctive paired depressions or pits right on the lower lip, along with hypodontia, which is usually absent second premolars.
Got it. Now, when you're an examiner reviewing a resident's clinical notes, you want to see standard classifications. You can't just write cleft lip on the right. How do we rigorously classify these defects?
You really need to be fluent in two main systems. The first is Kernahan stripe Y. So imagine a capital letter Y.
Okay, picturing a Y.
The intersection of the three arms represents the incisive foramen. The two upper branches of the Y represent the right and left sides of the primary palate, so the lip and the alveolus.
And the stem.
The single vertical stem of the Y represents the secondary palate, the hard and soft palate. You physically shade in the blocks on this diagram on the chart. Stippling an entire block means a complete cleft. Stippling half a block means an incomplete cleft.
What if you crosshatch it?
Crosshatching the block indicates a submucous cleft, where the mucosa is intact, the skin is there, but the underlying muscle has failed to fuse.
So it's basically a visual heat map of the defect. The second system, LaChal, is alphanumeric, right?
Yes. LaChal is an acronym that spells out the anatomy from the patient's right to their left. So lip, alveolus, hard palate, soft palate, hard palate, alveolus, lip. LAHSHAL.
And how do you use the letters to describe the severity?
It's highly specific. If you see a capital letter, it denotes a complete cleft through that specific structure. A lowercase letter denotes an incomplete cleft.
What if there's no cleft in that spot?
A dot. A dot means the structure is intact, and an asterisk denotes a microform cleft, a minimal manifestation, like a small notch in the lip margin or just a streak of scar tissue.
Okay, so give me an example. If a patient's chart reads capital L, lowercase a, ... what does that mean?
Immediately they have a right-sided complete cleft lip because of the capital L, with an incomplete cleft of the right alveolus because of the lowercase a, and the rest of the palate and left side are perfectly normal. It's all the dots.
Okay, let's take that exact patient into the operating room. We are repairing a unilateral cleft lip. There are two historical heavyweights when it comes to technique here: the Millard rotation advancement and the Tennyson-Randall Z-plasty. Break down the mechanical philosophy behind the Millard technique. Why is it the workhorse?
The sheer genius of Ralph Millard's rotation advancement technique is how it camouflages the scar. So in a unilateral cleft lip, the tissue on the medial side of the cleft, the center of the lip, is naturally pulled upward toward the nose.
Right.
Millard's solution is to make a curved incision that releases this medial tissue, allowing it to drop down or rotate into a normal horizontal position.
But doesn't that leave a hole?
It does. It creates a triangular gap right at the top of the lip, near the base of the nose. So to fill that gap, you take a triangular flap from the lateral side of the cleft, and you literally advance it into the defect.
And the beauty of that design is really where the final suture line lands, isn't it?
That's the primary advantage, yeah. The main vertical scar perfectly mimics the natural filter column on the cleft side. Furthermore, it's a dynamic procedure. It's known as a cut-as-you-go technique.
Meaning you can change the plan mid-surgery.
Exactly. If the lip isn't long enough once you've made your initial rotation, you can just extend the back cut at the top of the incision to drop the lip down even further while you are actively operating.
Wow. But it's not without its flaws, I assume.
Right. It definitely has a steep learning curve. The geometric design relies heavily on tissue elasticity, which varies wildly from patient to patient. And because you are advancing a flap directly under the nostril, there can be significant tension at the nostril sill.
Which causes widening.
Yeah, it leads to widening of the nasal floor. And, if you misjudge your rotation, the most common poor outcome is a lip that is vertically too short. It pulls upward and exposes the teeth constantly.
Okay, so how does the Tennyson-Randall technique attempt to solve those specific problems?
Well, the Tennyson-Randall completely abandons the high rotation in favor of a classic lower Z-plasty. So instead of putting the tension at the top of the lip near the nose, it places a geometric triangular flap right near the vermilion border, the red part of the lower lip.
What's the advantage of doing it that way?
The primary advantage is mathematical precision. You measure your landmarks with calipers, you draw your triangles, and you cut. It's much easier to teach, and it places the maximal tension low down, near the alveolar ridge.
Which is good for the lip shape.
Very good. It naturally helps push the lip out into a normal, nice pout.
But if it's so mathematically precise, why isn't it the standard everywhere?
Because that precision comes at the cost of flexibility. Once you commit to your caliper measurements and make your cuts, you cannot adjust it intraoperatively. There is no cut-as-you-go here.
So if you're wrong, you're stuck.
Exactly. And more importantly, from an aesthetic standpoint, the resulting scar cuts diagonally straight across the lower portion of the philtrum. It completely destroys the natural aesthetic lines of the upper lip. And if a Tennyson-Randall goes wrong, you end up with a lip that is vertically too long, which is incredibly difficult to revise.
Yikes. Okay, let's move posterior to the cleft palate. For the exam, you need to understand not just how we close the palate, but when we close it, because it is basically a battle between facial growth and functional speech.
It is a very delicate compromise. If you operate on the palate too early in infancy, the extensive scar tissue from the surgery will actually tether the maxillary bone.
And that stops the face from growing.
Yes, it severely restricts midfacial growth, leaving the patient with a sunken midface as they grow up. However, if you wait until the child is, say, 2 or 3 years old to spare the bone growth, they will have already missed the critical window for speech development.
Oh, so they learn to speak incorrectly.
Right. They develop severe compensatory articulation errors that are nearly impossible to unlearn later in life. Therefore, the gold standard timing is to repair the palate right before the onset of meaningful speech acquisition.
Which is around when?
Typically between 6 to 8 months of age, right before they begin consonant babbling.
Okay, so when you make that incision and lift the mucosal flaps, what are you actually looking for? Because this isn't just a simple skin closure. It's a complex muscle reconstruction.
This is the core of palate surgery. You have to realize the soft palate isn't just a static curtain hanging there. It's a highly dynamic muscular valve. And the single most important muscle in that valve is the levator veli palatini.
And what does that muscle normally do?
In a normal patient, The levator muscle originates from the skull base, comes down, and forms a transverse sling across the midline, literally interdigitating with the muscle from the other side. When it contracts, it acts like a hammock,
Pulling the palate up.
pulling it up and backward, yeah. It smacks against the posterior pharyngeal wall, completely sealing off the nasal cavity so you can actually pronounce consonants like P and B.
But in a cleft palate, that hammock is just ripped in half.
It's worse than a ripped, really. The muscle fibers never even cross the midline in the first place. Instead of running transversely, they run longitudinally, parallel to the cleft edge.
Where do they attach, then?
They insert abnormally into the hard, bony posterior edge of the palate, so when they contract, they just pull the edges of the cleft tighter against the bone. They don't elevate the palate at all.
So the entire goal of, like, an intravelar veloplasty or a furlough double approaching Z-plasty is to essentially rebuild that hammock.
Exactly. The surgeon must sharply dissect those abnormal muscle fibers completely away from the hard palate, reorient them a full 90 degrees so they lie transversely, and suture them together in the midline.
How does the furlough Z-plasty differ from that?
The furlough Z-plasty takes us a step further. It uses opposing Z-plasties on the oral mucosa and the nasal mucosa. By transposing those triangular flaps, it not only reorients the muscle sling, but it physically borrows tissue from the width of the palate to add length to the soft palate.
And that length is crucial, right? Because if the repaired palate is too short, or if that muscle sling is weak, the valve fails. The patient develops velopharyngeal insufficiency, or VPI. When they speak, air escapes up into the nasal cavity. They sound really hypernasal.
Right.
So if a patient comes to your clinic with VPI, how do you mathematically prove what's wrong before you propose a surgical fix?
Well, you cannot operate blindly on VPI. You absolutely must understand the fluid dynamics of their specific airway port. So we use two main diagnostic modalities. First is multi-view video fluoroscopy.
Where they swallow the dye.
Yes, the patient swallows barium, and we watch the palate move under continuous X-ray while they speak. We're looking at the absolute length of the soft palate, how far it elevates, and we're looking at the posterior pharyngeal wall to see if it bulges forward to meet the palate.
What's that bulge called again?
That's a phenomenon called passavance ridge.
Right. And what's the second modality?
Nasendoscopy. We pass a flexible scope through the nose and watch the valve from above while the patient repeats specific phonetic phrases. We are looking for the exact pattern of closure.
What kind of patterns are we looking for?
Well, is the gap coronal, meaning the palate just doesn't reach the back wall? Or is it sagittal, meaning the lateral walls of the throat aren't squeezing inward enough? Or is it circular?
Let's say the problem is purely coronal. The palate elevates well, but it's just structurally too short to reach the back wall. What is the surgical solution?
That is the classic indication for a superiorly based posterior pharyngeal flap. The surgeon literally goes to the back of the throat, cuts a long rectangular flap of mucosa and muscle, leaves it attached to the top near the adenoids, and sews the bottom end directly into the soft palate.
Wait, you are literally creating a permanent bridge of tissue connecting the palate to the back wall.
Yes, a permanent bridge. And because it's superiorly based, as the flap heals and naturally contracts, it pulls the soft palate even further up and back.
But how do they breathe through their nose?
The air and mucus must now pass through the two lateral ports left on either side of that central bridge.
Ah, okay. But this requires the lateral pharyngeal walls to have good, strong movement to squeeze shut against the bridge, right? What if the nasendoscopy shows the lateral walls are completely paralyzed or weak? A bridge won't help. The air will just leak right out the sides.
That is exactly why we have the sphincter pharyngoplasty, popularized by Hines and Orticochea. If the lateral walls don't move, you have to artificially narrow the entire ring.
How do you do that without a bridge?
Instead of a central bridge, the surgeon raises two flaps from the posterior tonsillar pillars, which actually contain the palatopharyngeus muscle. These flaps are rotated inward, flipped horizontally, and sutured right across the posterior pharyngeal wall.
Creating like a speed bump.
Exactly. Creates a permanent, bulky, muscular speed bump. This dramatically reduces the overall circumference of the port, making it much easier for a weak palate to achieve closure.
Amazing. Okay, let's shift our focus from the facial midline up to the cranial vault. We are talking about craniosynostosis, the premature fusion of the skull sutures. And the guiding principle here is Virchow's law. Walk us through the biomechanics of a growing skull.
Sure. Think of an infant skull not as a solid bone, but as a series of tectonic plates separated by expansion joints. Those joints are the sutures, The driving force of skull growth is the rapidly expanding brain underneath.
It's just pushing outward.
Right. As the brain grows, it pushes outward uniformly. Virchow's law states that when one of those expansion joints fuses prematurely, growth perpendicular to that fused suture is completely arrested. But the brain still needs to grow.
So it forces the skull to expand parallel to the fused suture, taking the path of least resistance. It's the balloon analogy. Like if you grip a balloon with your hand right around its middle, restricting its width, and you keep blowing air into it, the balloon is forced to bulge out at the top and the bottom.
That is an excellent way to visualize it, yeah.
Mm.
If we apply that to the sagittal suture, which runs front to back down the midline of the skull, a premature fusion stops the skull from growing out to the sides.
So what shape does the head take?
The brain forces the skull to grow excessively long from front to back. The result is a very narrow, elongated, boat-shaped head. We call this scaphocephaly or dolichocephaly.
Okay, what if the fusion happens transversely? The coronal sutures run side to side across the top of the head from ear to ear, right?
Right. If both coronal sutures fuse, which is bicoronal synostosis, the skull cannot expand front to back. The brain forces compensatory growth sideways and upward.
So the head gets really wide.
Very short posteriorly, very wide, and often very tall. This is called brachycephaly. And if the metopic suture, which runs down the exact middle of the forehead from the fontanelle to the nose, if that fuses early, the forehead cannot grow wide.
What happens then?
It pinches inward, creating a sharp, triangular-shaped forehead known as trigonocephaly. You'll often feel a palpable ridge of bone running right between the eyes.
Now, on the boards, they love to test your ability to differentiate between true synostosis, which requires major cranial vault reconstruction, and just positional plagiocephaly, which requires a helmet or maybe just repositioning the baby. Let's say an infant presents with an asymmetric flattened head. How do you distinguish positional plagiocephaly from true unilateral coronal synostosis just on a physical exam?
You have to look at the infant's head from a bird's eye view, directly from above. In positional plagiocephaly, the deformity is caused by external pressure, usually because the infant sleeps on the exact same spot on the back of their head every single night.
Which flattens the back of the head.
Right, that continuous pressure flattens the occiput. But it doesn't just flatten the back. It pushes the entire ipsilateral side of the face forward.
So it creates sort of a parallelogram shape.
Exactly. The flattened occiput pushes the ear on that side forward, and it pushes the forehead on that side forward. Everything shifts on a diagonal axis. But true unilateral coronal synostosis is a totally different geometric shape.
Because the suture is glued shut?
Yes. One side of the coronal suture is glued shut. That side of the forehead physically cannot grow forward. The skull shape becomes a trapezoid, or it looks pinched. The forehead is severely flattened and retruded on the fused side.
And the brain just bulges out the other way.
Exactly. Seeking that path of least resistance, it bulges out the opposite side, causing a contralateral frontal bossing. And crucially, the ear on the fused side is usually pulled upward and backward, not pushed forward like in positional plagiocephaly.
That structural understanding is so key. Now, we must overlay the genetic syndromes onto these fusion patterns. Aperts, Crouzons, Saythrich-Shotson, Pfeiffer's, these are autosomal dominant conditions, largely involving fibroblast growth factor receptor mutations. Let's start with Apert syndrome.
So Apert's is caused by an FGFR2 mutation. The cranial presentation is almost always a severe bichromal synostosis, giving them a cowering brachycephalic skull. They have significant mid-face hypoplasia, so the upper jaw and cheekbones fail to grow forward, creating a very concave facial profile.
And the eyes.
Because the orbits are shallow, their eyes bulge outward. We call that condition exorbitism. Roughly 20% will also have a cleft palate. But the absolute defining feature of Apert's, the thing you look for the second they walk in the clinic, is their extremities.
The syndactyly.
Yes. They present with complex symmetric syndactyly of both the hands and the feet. The digits are fused together not just by skin, but often by a solid bony mass, creating what's classically described as a mitten hand or rosebud hand deformity.
Wow. How does Crouzon syndrome differ from that?
Crouzon's is also an FGFR2 mutation, and facially, it actually looks very similar. They have bicoronal synostosis, terrible mid-face hypoplasia, and severe exorbitism. But the distinguishing factor is that their hands and feet are completely normal. There is no syndactyly.
What's the main clinical danger with Crouzons then?
The clinical danger that examiners really focus on is that these patients have a much higher rate of progressive hydrocephalus and chronically raised intracranial pressure. You must actively monitor their optic discs for papilledema to prevent blindness.
Let's round out the syndromic fusions with Sather-Chatson and Pfeiffer's.
So Sather-Chatson is unique because it's caused by a twist-1 gene mutation, not an FGFR mutation. Their bicoronal fusion is often asymmetrical.
What do you see on a physical exam for them?
The hallmark physical exam findings are a very low frontal hairline, severe petosis, which is drooping of the upper eyelids, and uniquely dysplastic ears with a prominent overarching crus. They may have mild cutaneous syndactyly, like some webbing between the second and third fingers, but never that bony mitten hand of Apert's.
And Pfeiffer.
Pfeiffer syndrome goes back to the FGFR mutations, and its undeniable hallmark is broad, deviated great toes and broad thumbs, alongside the craniosynostosis and severe exorbitism.
Okay, let's shift from conditions where bones fuse too early to conditions where the tissue never fully develops in the first place. The atrophy hypoplasia categories: hemifacial microsomia and Treacher-Collins syndrome.
Right, so hemifacial microsomia is fundamentally a unilateral underdevelopment of the first and second branchial arches. The severity is wildly variable. To standardize communication, we use the Omens classification system.
Omens. Break that down for me.
O stands for orbital distortion. M is for mandibular hypoplasia. E is for ear deformity, which ranges from mild tags to complete microcia. N is for nerve involvement, specifically the facial nerve. And S is for soft tissue deficiency.
Within the Omen system, the mandible is basically the structural cornerstone, and we grade the mandible using the Przansky classification. Break down those grades.
The Przansky grade actually dictates your surgical approach. Type I means the mandible is a miniature but morphologically normal replica. All the parts are there, they're just small.
And Type 2.
Type 2 means the anatomy is actually distorted. The ramus is short and abnormally shaped. We divide Type 2 into iia, where the temporomandibular joint, the TMJ, is deformed but still functionally articulates with the skull, and iib, where the joint is so distorted it no longer properly articulates at all.
What about Type 3?
Type 3 is the absolute extreme. It's a complete absence of the mandibular ramus, the condyle, and the TMJ. There's simply no bone there.
If hemifacial microsomia is usually unilateral, Treacher-Collins syndrome is sort of the devastating bilateral counterpart.
Yes. Treacher-Collins is an autosomal dominant condition characterized by bilateral symmetric hypoplasia of those exact same first and second branchial arch derivatives. The bony defects correlate perfectly with confluent Kessier 6, 7, and 8 clefts straight through the cheekbones.
So the cheekbones are just gone?
The zygomas, the malar eminences, are severely hypoplastic or completely absent, yeah. It gives the face a sunken convex profile with a really prominent beak-like nose and a severely retrusive chin.
The soft tissue findings around the eyes are also pretty pathognomonic.
Very. They have a distinct anti-mongoloid slant, so downward slanting palpebral fissures. They frequently have colobomas, which are full-thickness notches or clefts in the outer third of the lower eyelids, and they are completely missing their eyelashes medial to those colobomas.
But the facial aesthetics are entirely secondary to the immediate physiological crisis these children face at birth. What is the absolute board exam priority for Treacher-Collins?
The airway. It is always, always the airway. Because both sides of the mandible are profoundly hypoplastic, the tongue is pushed entirely into the pharyngeal space.
So they can't breathe.
They present with catastrophic airway obstruction and severe feeding difficulties the literal moments they are born. They often require emergency intubation, prone nursing to let gravity pull the tongue forward, and very frequently an early surgical tracheostomy just to keep them alive while you plan jaw distraction osteogenesis.
That provides a perfect transition into our next major section, maxillofacial trauma. You are called to the ER. A patient has suffered a severe facial crush injury from a motor vehicle accident. The midface is entirely mobile. What is the algorithmic approach?
You never start by examining the facial fractures. You always start with the ATLS protocol, Advanced Trauma Life Support. Airway maintenance with cervical spine protection is paramount.
Why is airway so tricky here?
In massive midface trauma, there is a very high probability that the fracture lines extend upward through the cribriform plate of the ethmoid bone, which sits right in the base of the skull. The dura might be torn. Therefore, you are absolutely contraindicated from performing a blind nasotracheal intubation or even inserting a simple nasogastric tube.
Because if you push a tube blindly up the nose and the cribriform plate is shattered,
you will pass that tube directly into the anterior cranial fossa and straight into the frontal lobe of the brain. It is a catastrophic, fatal error. You must establish an oral airway or perform a surgical cricothyroidotomy.
Wow. Okay, once the patient is neurologically cleared and stable, we classify the midface skeletal damage using the Lefort system. René Lefort, back in the early 1900s, quite literally dropped cannonballs on cadaver skulls to observe where the face structurally failed.
Yeah, quite the experimental design.
He discovered that the facial skeleton has thick pillars of bone buttresses designed to absorb force and thin plates of bone in between. When overwhelming force is applied, the face fractures predictably along the weak planes between those buttresses. Describe the path of a Lefort eye fracture.
So, Lefort's fourth is the lowest horizontal weak plane. A straight-on blow to the upper lip typically causes it. The fracture line passes horizontally right above the teeth, straight through the base of the piriform aperture of the nose, laterally through the anterior walls of the maxillary sinuses, and crucially, it extends posteriorly to fracture the pterygoid plates.
The clinical hallmark of a Lefort fourth is the floating palate, right? If you grab the patient's upper teeth and pull forward, the entire upper jaw moves, but the nose and cheekbones stay perfectly still.
Exactly. Lefort's third is the pyramidal fracture. The force is delivered slightly higher up, usually to the nasal bridge. The fracture line starts at the nasal bones, travels downwards and diagonally backward into the medial wall of the orbit behind the lacrimal bone.
And then where does it go?
It passes over the inforbital rim, drops down under the strong zygomatico-maxillary buttress, the cheekbone strut, and again travels posteriorly to fracture the pterygoid plates. If you grab the teeth in a Lefort third, the upper jaw and the nose move together as a single pyramid-shaped block.
And Lefort third is the most severe, craniofacial disjunction.
Yeah, the force here is massive and applied high on the face. The entire facial skeleton is basically sheared off the cranial base.
Where's the fracture line?
It passes horizontally through the nasofrontal suture at the top of the nose, travels straight backward entirely across the orbital floors, comes out laterally through the zygomaticofrontal suture at the outer corner of the eye, drops through the zygomatic arch, and fractures high up on the pterygoid plates.
So the whole face is detached.
The entire face, from the eyebrows down, is detached and pushed backward into the skull base, giving this sort of flattened, dish face deformity.
In reality, pure Lefort fractures are rare, right? A patient will usually have like a Lefort test on the right side and a Lefort throw on the left. But the classification guides your reconstruction, which always proceeds from stable bone to unstable bone. Now let's talk about the mandible. It's an exposed U-shaped bone hanging off the skull. It breaks constantly. The condyle accounts for 36% of all fractures. But when deciding whether to put plates and screws into a fractured jaw, we must evaluate the muscle vectors. Explain the concept of favorable versus unfavorable fractures.
Well, the mandible is suspended by powerful muscles pulling in opposite directions. The muscles of mastication, the masseter, temporalis, and medial pterygoid, they attach to the angle and ramus, pulling the back of the jaw forcefully upward and forward.
And the front muscles?
Meanwhile, the suprahyoid muscles, like the digastric, they attach near the chin and pull the front of the jaw downward and backward. Whether a fracture is favorable or unfavorable depends entirely on the geometric angle of the fracture line relative to those two opposing muscular forces.
So let's say a patient has an angle fracture.
Right. If the angle of the fracture line is oriented such that the masseter pulling up and the digastric pulling down naturally compress the two broken ends of bone tightly together, that is a mechanically favorable fracture.
Because the muscles are basically acting like an internal splint.
Yes. But if the fracture line is angled the other way, those exact same muscles will pull the posterior fragment up and drop the anterior fragment down, basically splaying the fracture wide open. That is an unfavorable fracture. It is mechanically unstable and highly prone to displacement, which ruins the patient's dental occlusion.
When we take that unstable fracture to the operating room, we have to choose our hardware. The exam always tests the biomechanical concepts of load-bearing versus load-sharing. What's the difference?
Load-bearing means the titanium plate you install assumes 100% of the functional stress of chewing. The bone takes zero force.
So you need big plates.
Huge ones. You must use massive, rigid reconstruction plates secured with heavy bicortical screws. This is absolutely mandatory if the fracture is severely shattered into multiple pieces, if there's a missing gap of bone, or if the patient has a thin, atrophic, toothless mandible that just lacks the structural integrity to support itself.
And load sharing is a more elegant approach, but it requires specific conditions.
Yes, very specific. In load sharing, the bone fragments are healthy enough that they can be compressed together to absorb some of the chewing force, basically sharing the burden with the hardware. We use much smaller, thinner Champy miniplates.
Where do those go?
The crucial detail is that these miniplates must be placed along Champy's ideal lines of osteosynthesis, which are the specific tension bands along the upper border of the mandible. We rely heavily on the friction between the fractured bone ends to provide the structural stability.
Before we leave trauma, we really need to address orbital floor blowouts, specifically the criteria for surgical intervention.
Yep.
When do we just observe and when do we rush them to the OR?
There is one scenario that is an absolute immediate drop-everything surgical emergency, a retrobulbar hematoma.
Which is basically an acute compartment syndrome of the eye.
Exactly. A bleed occurs behind the globe. Because the orbit is a closed bony cone, the extending hematoma rapidly increases intraocular pressure, compressing the optic nerve and literally shutting off the arterial blood supply to the retina.
How does the patient present?
They will have agonizing eye pain, a rock-hard globe, severe proptosis where the eye is just bulging outward, and rapid visual loss, often first noticed as red color desaturation. On physical exam, they will have a relative afferent pupillary defect, the Marcus Dunn pupil.
So you run them to the scanner?
No. You absolutely do not wait for a CT scan. You do not wait for an OR. You intervene right at the bedside.
What do you do?
You inject local anesthetic, take scissors, and perform a lateral canthotomy, cutting horizontally through the outer corner of the eyelids down to the bony rim. Then you perform a cantholysis.
Meaning you pluck the tendons.
You pluck the inferior and superior limbs of the lateral canthal tendon like guitar strings and cut them. This completely detaches the eyelid from the bone, allowing the globe to instantly spill forward, decompressing the orbit and saving the optic nerve.
That is intense. Okay, that's the sight-saving emergency. What if it's just a standard blowout fracture where the floor drops into the maxillary sinus, but there's no hematoma?
That requires urgent surgery, usually within 2 weeks, to prevent permanent deformity. The main indications for surgery are enophthalmos, where the eye sinks backward into the skull more than 2 millimeters because the orbital volume has expanded, or functionally debilitating diplopia, which is double vision.
But diplopia can just be from swelling, right? How do you prove it's a mechanical entrapment of the muscle requiring surgery?
You perform a forced duction test. You apply topical anesthetic to the eyeball, physically grab the sclera with fine-toothed forceps, and try to manually rotate the eye upward.
And if it moves?
If it moves freely, the double vision is just from nerve bruising or edema. But if it feels like it is tethered to an anchor and physically will not rotate, the inferior rectus muscle is mechanically entrapped in the trapdoor fracture of the orbital floor.
And when you are surgically trying to free that entrapped muscle, there's a physiological reflex that can shock the entire room.
Oh yeah, the oculocardiac reflex. The trigeminal nerve carries the afferent sensory signal from the stretched muscle, and the vagus nerve carries the efferent parasympathetic signal directly to the heart.
So what happens?
The moment you tug on that entrapped tissue with your retractor, the patient's heart rate will instantly plummet. The anesthesiologist will usually yell out that the patient is bradycardic. You must immediately let go of the tissue, allow the heart rate to recover, and strongly consider administering atropine before continuing with a much, much gentler dissection.
Let's transition into head and neck oncology and reconstruction. To talk about clearing out metastatic disease, we first have to speak the language of the neck. Neck dissections are notoriously complex to memorize, but they rely on a rigid geographical map. Walk us through the 6 levels of the neck.
Imagine the neck as a grid. Level UN is the area right up under the jawbone. It's divided into level IA, the submental triangle under the chin, and level GIB, the submandibular triangle containing the submandibular gland.
Okay, that's the top. What about the rest?
Levels 2, 3, and 4 trace the path of the internal jugular vein straight downward. Level 2 is the upper third, from the base of the skull down to the hyoid bone. Level 3 is the middle third, from the hyoid down to the cricoid cartilage. Level 4 is the lower third, from the cricoid down to the clavicle.
So that's the central vertical column. Where is level V?
Level V is the entire posterior triangle of the neck. It basically sits behind the sternocleidomastoid muscle and extends all the way back to the trapezius. Level 6 is the anterior central compartment, sitting vertically right over the thyroid gland and the trachea.
Okay, knowing that map, we can define the operations. What exactly constitutes a classic radical neck dissection?
The radical neck dissection, originally described by Crenel, is a highly aggressive en bloc resection designed to clear widespread metastatic disease. It strips out every single lymph node in levels I through V.
But it takes more than just nodes, right?
Right. The defining feature is the purposeful sacrifice of 3 major non-lymphatic structures to ensure complete tumor clearance: the spinal accessory nerve cranial nerve, XI, the internal jugular vein, and the sternocleidomastoid muscle.
The morbidity of that procedure must be immense, specifically because of the spinal accessory nerve.
It is. The loss of the spinal accessory nerve completely paralyzes the trapezius muscle. The patient suffers severe shoulder drop, chronic pain, and an utter inability to abduct their arm above 90 degrees. It is really debilitating.
So what's the alternative?
Because of this, surgeons evolved the modified radical neck dissection. This procedure still clears out the entire lymphatic basin of levels I through V, but it spares one or more of those three non-lymphatic structures. The most common variation is sparing the spinal accessory nerve to preserve shoulder function, provided, of course, the tumor isn't directly invading it.
And if the disease is more localized?
Then we perform a selective neck dissection. We spare specific uninvolved lymph node levels based entirely on the predictable lymphatic drainage pathway of where the primary tumor originated.
For example?
Well, a cancer of the oral cavity predictably drains to levels 1, 2, and 3, so we perform a supremo-hide neck dissection, clearing only those upper levels and sparing levels 4 and V completely.
Okay, once the ablative surgeon removes the tumor, the plastic surgeon has to rebuild the defect. Let's say the patient had a massive squamous cell carcinoma of the mandible, requiring a segmental resection. We need to replace the bone. How do we choose between the big three? The fibula, the DCIA, and the radial forearm osteocutaneous free flaps. Let's start with the workhorse, the fibula.
The fibula free flap is the undisputed champion of mandibular reconstruction for several reasons. First, it offers up to 25 centimeters of straight, dense cortical bone, allowing you to reconstruct massive defects extending from angle to angle.
And the blood supply.
Biomechanically, it is classified as a Mathis and Nahai type V flap, supplied primarily by the peroneal artery.
The magic of the fibula is its periosteal blood supply, isn't it?
Exactly. The peroneal vessels run right along the bone, sending tiny segmental perforators directly into the periosteum, which is the sleeve of tissue wrapping the bone.
Why does that matter?
Because the blood supply is segmental. A surgeon can take that long, straight fibula bone and make multiple closing wedge osteotomies, basically saw cuts through the bone, to snap and bend it into the precise U shape of a jaw. As long as that periosteal sleeve remains intact, every small segment of bent bone stays perfectly vascularized and alive.
Wow, that's clever. But the fibula isn't perfect, is it? The bone is relatively narrow. If the patient eventually wants osseointegrated dental implants to chew food, a thin fibula might not provide enough vertical height to anchor the metal posts. How does the DCIA flap solve that?
The deep circumflex iliac artery, or DCIA, flap harvests bone from the anterior iliac crest of the pelvis. This provides a massive, thick, tall block of bone, which is absolutely ideal for supporting heavy dental implants.
Plus, the shape is nice.
Yeah. The major reconstructive advantage of the DCIA is that the natural sweeping curve of the human pelvis often perfectly mimics the natural curve of a hemimandible. You can harvest a piece of the hip that requires absolutely no osteotomies. You just slot it into the jaw defect like a puzzle piece.
So why isn't it used all the time then?
Because the harvest causes significant donor site morbidity. The patient will have a severe skin paddle attached to the DCIA is very bulky, inflexible, and notoriously less reliable in its vascularity compared to the fibula skin paddle. It is very hard to contour inside the mouth.
Okay, what about the radial forearm osteocutaneous flap?
The radial forearm flap is spectacular for providing thin, pliable, highly reliable soft tissue for intraoral lining. But as a bone flap, it is deeply flawed.
Why? Is there not enough bone?
You can only safely harvest a superficial wedge from the radius bone no more than 40% of its circumference. This means the bone height is extremely low, making dental implants nearly impossible.
And the arm itself?
That's the terrifying part. Harvesting that wedge significantly weakens the patient's arm, putting them at a high risk of a catastrophic radius fracture post-operatively with even minor trauma.
That doesn't sound worth it. Let's pivot to salivary gland tumors. There is a classic rule of 80s that examiners expect you to recite.
The rule of 80s is a quick statistical shortcut. It states that 80% of all salivary gland tumors are located in the parotid gland. Of those tumors in the parotid, 80% are benign. And of those benign tumors, by far the most common histology is the pleomorphic adenoma.
But here's the catch. Even though a pleomorphic adenoma is technically benign, surgical management is extremely aggressive. Why?
Because of its microscopic behavior. A pleomorphic adenoma has pseudopodia, these tiny, microscopic, finger-like projections of tumor cells that push completely through the main tumor capsule into the surrounding normal gland.
So if you just pluck the tumor out,
if a surgeon just cuts open the gland and shells out the tumor mass, a simple enucleation, they will inevitably leave those microscopic fingers behind. This leads to multifocal, unacceptably high recurrence rates.
and can it turn cancerous?
Yes, if left in the body long enough, a benign pleomorphic adenoma has a known risk of undergoing malignant transformation into a carcinoma ex pleomorphic adenoma.
Therefore, the minimum acceptable surgery is a superficial parodidectomy, basically removing the tumor along with the entire superficial lobe of the gland to ensure a wide cuff of normal tissue. But the entire parotid operation is a high-stakes dance around the facial nerve. How do you safely find it?
Well, the facial nerve exits the skull base and plows directly through the middle of the parotid gland, literally splitting it into superficial and deep lobes. Finding it is the hardest part of the operation. You have two approaches, antegrade and retrograde.
Let's start with antegrade.
The antegrade approach is the gold standard. You hunt for the main trunk of the nerve right where it exits the stylomastoid foramen before it even enters the gland.
What are the anatomical landmarks for the main trunk?
The most reliable landmark is the tragus pointer. The tragus is that small cartilage bump in front of the ear canal. The medial, deep tip of that cartilage points directly to the facial nerve.
How far away is it?
The nerve is typically located exactly 1 centimeter deep and 1 centimeter anterior and slightly inferior to the tragus pointer. You can also use the tympanomastoid suture line as a guide.
And once you find the trunk?
Once you find that thick main trunk, you meticulously trace it forward as it bifurcates into the pes and serenus and splits into all the branches: the temporal, zygomatic, buccal, marginal mandibular, and cervical branches.
But what if there is a massive tumor sitting directly over the main trunk? You can't use the antegrade approach without cutting into the tumor.
In that case, you are forced into the retrograde approach. You must find a tiny distal branch of the nerve way out in the face and carefully trace it backward, upstream, right into the gland.
How do you even find a tiny branch?
A common method is to locate the marginal mandibular branch where it predictably crosses over the facial artery and vein at the lower border of the jaw. Alternatively, you can find a buccal branch running horizontally right alongside the carotid duct. You find the thread and you follow it back to the knot.
That sounds incredibly tedious. Let's move to a highly specialized area of reconstruction, oculoplastic surgery. The eyelids require an incredible respect for microscopic anatomy. What are the absolute non-negotiable rules for eyelid reconstruction?
The fundamental concept of eyelid anatomy is the lamellae. Think of the eyelid as a sandwich. The anterior lamella is the outer layer, the very thin skin, and the underlying orbicularis oculi muscle.
And the inner layer?
The posterior lamella is the inner layer, the rigid structural tarsal plate that gives the lid its shape, which is lined on the inside by the mucosal conjunctiva.
How do you tell where they meet?
The dividing line between these two layers is visible right on the eyelid margin as the gray line. The cardinal rule of full-thickness reconstruction is that you must independently reconstruct both lamellae, and at least one of those reconstructed layers must have its own native blood supply.
And what is the most important physiological rule regarding tissue matching?
You must never, under any circumstances, use skin to reconstruct the posterior lamella.
Why? What happens?
The inside of the eyelid rubs against the cornea thousands of times a day. If you place skin there, the keratin layer, and especially the fine lanugo hairs growing out of the skin, will act like biological sandpaper. They will abrade the cornea, cause agonizing ulcerations, and ultimately blind the patient.
So what do you use instead?
The posterior lamella must be reconstructed with a smooth mucosal surface, like conjunctiva, a hard palate mucosal graft, or nasal chondromucosa.
Okay, let's walk the reconstructive ladder for lower eyelid defects. Say you excise a small basal cell carcinoma. If the defect is less than 13 of the total width of the lower lid, what is the approach?
A defect that's small can usually be closed primarily, but you must ensure you excise it as a perfect pentagonal wedge. You want your incisions through the rigid tarsal plate to be perfectly vertical so that when you bring the edges together, they abut flatly against each other without buckling or causing a notch in the lid margin.
What if the defect is larger, say between 13 and 23 of the lid width? You can't pull that shut without massive tension.
Primary closure here is dangerous because the tension will pull the lower lid downward, away from the eye, a condition called ectropion, which leaves the eye chronically exposed and tearing. To close this defect, you must borrow tissue from the side. The workhorse here is the tensile semicircular rotation flap.
So wait, if you're taking tissue from the side, how do you even get it to stretch over? Walk me through the exact geometry of the tensile. If I'm holding the scalpel, where's my incision starting?
You start your incision right at the lateral canthus, the outer corner of the eye. You carry the incision upward and outward in a wide semicircle directly into the temporal skin. But simply cutting the skin isn't enough. The flap won't move. You must perform a lateral cantholysis.
So you're basically snipping the anchor.
Exactly. You go deep and surgically cut the inferior crust of the lateral canthal tendon, physically detaching the lower lid from the orbital rim. With the tendon cut and the semicircular skin flap elevated, the entire lateral complex is mobilized.
And then you just swing it over?
You rotate the flap medially to fill the defect, and you anchor the new lateral edge up to the periosteum to recreate the canthus.
And for massive defects, greater than 23 of the lower lid, up to a total loss of the lid, a tensile flap won't stretch nearly that far.
For massive lower lid defects, you must import brand new tissue. The gold standard is the Hughes tarsoconjunctival flap. Because you are missing both lamellae, you have to reconstruct them sequentially. The Hughes flap borrows a perfect posterior lamella from the healthy upper eyelid.
Wait, if you cut the tarsus out of the upper lid, don't you destroy the upper lid's stability?
That's the trick. You don't take the margin. You evert the upper lid and harvest a rectangular flap of tarsus and conjunctiva from higher up, leaving the crucial distal 4 millimeters of the upper eyelid margin completely intact.
Oh, it's smart.
Yeah, you drop that rectangular flap down like a window shade and sew it into the lower lid defect. You have now rebuilt the posterior lamella with perfect, smooth conjunctiva. But as a result, the eye is now physically sewn shut.
It's a shared flap covering the eye. What about the anterior lamella?
With the posterior lamella in place, you simply place a full-thickness skin graft or a local advancement flap directly over the vascularized Hughes flap to recreate the anterior skin. Because the eye is sewn shut, the patient obviously has no vision in that eye.
How long does it stay like that?
You wait about 3 to 4 weeks for the blood supply to grow into the graft from the lower lid edges. Once it takes, you return to the OR, take scissors, and physically divide the conjunctival flap, separating the upper and lower lids again and restoring the patient's vision.
What if the massive defect is on the upper lid? You can't use a Hughes flap in reverse because the lower lid tarsus is just too small and structurally weak to replace a massive upper lid tarsus.
Exactly. For upper lid defects greater than 23, we use the Cutler-Beard procedure. It's also a flap that sews the eye shut, but it is a full-thickness bridge flap.
How does that one work?
You literally cut a full-thickness rectangle of tissue from the lower lid skin, muscle, and conjunctiva. But again, you leave the lower lid margin intact. You pass this rectangular block of tissue underneath the intact lower lid margin, pull it up over the cornea, and stitch it directly into the upper lid defect. You leave it tethered for several weeks, then divide it.
Let's shift from defects to functional dynamics. Ptosis, the drooping of the upper eyelid. The exam relies on your ability to evaluate the levator muscle because it dictates the surgical choice. How do you measure it?
You measure levator excursion. You hold a ruler vertically over the eye. You press your thumb firmly against the patient's brow to completely immobilize the frontalis muscle so they can't use their forehead to cheat.
Then what?
You ask the patient to look as far down as possible, mark the lid position, and then ask them to look as far up as possible. A normal, healthy levator muscle will pull the lid up by 12 to 15 millimeters.
If a patient presents with mild ptosis, say the lid droops 2 millimeters, but their levator excursion is excellent, greater than 10 millimeters.
This is usually involutional ptosis. The muscle is strong, but the attachments have thinned with age. We typically perform a Fasinella Servet procedure. This is a posterior approach done from the inside of the lid. We don't cut the skin.
What are you cutting then?
We simply clamp, excise, and suture a small wedge of Miller's sympathetic muscle and the very top edge of the tarsal plate. This shortens the posterior lamella, hoisting the lid up by 1 to 2 millimeters, relying on the strong, intact levator to do the rest.
What if the levator function is just fair? It only moves 4 to 10 millimeters.
Then the muscle is weakened, or upon neurosis, the tendon has stretched out or dehisced. We do an anterior approach, making an incision in the eyelid crease. We find the levator upon neurosis, advance it downward, and suture it tighter to the tarsal plate. It's basically like tightening a loose fan belt on a car engine.
But if the levator function is poor, like less than 4 millimeters of excursion, the muscle is essentially paralyzed or fibrosed.
You cannot tighten a dead muscle. The levator is useless. You have to recruit an entirely different motor system to open the eye. We perform a frontalis sling.
How does that work?
The most tested method is the Crawford technique. We harvest a long strip of autologous fascia lata from the patient's outer thigh. We thread this thick, fibrous band under the skin, weaving it from the upper eyelid margin deep to the orbital septum and anchoring it solidly into the frontalis muscle of the forehead.
So you are mechanically linking the eyelid directly to the eyebrow.
Exactly. Now, to open their eye, the patient physically raises their eyebrows. The frontalis muscle contracts, pulls on the fascia lata sling, and hoists the eyelid open.
That concept of recruiting new muscles leads perfectly into our discussion on complete facial nerve palsy. If the seventh cranial nerve is destroyed, half the face is paralyzed. The orbicularis oculi cannot close the eye, the zygomaticus cannot form a smile, and the buccinator cannot keep food in the cheek. How do we approach reanimation?
We conceptually divide procedures into static and dynamic. Static procedures are essentially just architectural rigging. They do not restore any active spontaneous movement. Their goal is purely to improve resting symmetry and protect the cornea.
Because if the eye can't close, the cornea ulcerates.
Precisely. The most common static procedure is implanting a rigid gold or platinum weight directly into the upper eyelid beneath the orbicularis muscle. We rely purely on gravity. When the patient relaxes the levator muscle to blink, the heavy metal physically drags the upper lid down to cover the cornea.
And for the mouth.
We can also use static fascia slings, tunneled from the zygoma to the corner of the mouth, to physically hitch up a drooping lip so the patient doesn't drool.
But static procedures don't allow a patient to express emotion. To restore a smile, we need dynamic reanimation. The critical variable here is time. How long has the nerve been dead?
That is the ultimate deciding factor. When a nerve is cut, the muscle it supplies undergoes denervation atrophy. If you can rewire the muscle with a nerve transfer within 12 to 18 months, the native facial muscles will wake up and function again.
But what if it's been years?
If the paralysis is long-standing, greater than 2 years, the native facial muscles undergo irreversible fibrosis. They just turn to scar tissue. Pushing an electrical signal into them is useless. You must bring in fresh, healthy, vascularized muscle from elsewhere in the body.
This is arguably the most complex, awe-inspiring operation in plastic surgery. The two-stage free-functioning muscle transfer. Walk us through stage 1, the cross-facial nerve graft.
The goal of dynamic reanimation is to create a spontaneous, synchronous smile. When the patient feels happy, both sides of the face should move automatically. To do that, we have to steal the electrical impulse from the healthy working side of the face.
How do you steal a signal?
In stage 1, we harvest a long sensory nerve from the leg, typically the sural nerve. We operate on the normal side of the face, identifying the facial nerve branches. We find a redundant, expendable nerve branch that controls smiling, often a zygomatic branch. We cut it, and we microscopically coapt, or sew, one end of our long sural nerve graft to it.
So you've basically plugged an extension cord into a live socket on the healthy cheek.
Exactly. We then tunnel that extension cord under the skin, straight across the upper lip, burying the free end in the paralyzed cheek. Now, we wait. Nerves grow incredibly slowly, about 1 millimeter per day.
That takes forever.
It does. We wait 6 to 12 months for the motor axons from the healthy facial nerve to physically grow all the way across the face, through the hollow tubes of the sural nerve graft, until they reach the paralyzed side.
You can actually track that microscopic growth clinically, right?
Yes, just by tapping on the skin of the lip and cheek. You are looking for a tingle sign, a tingling sensation that tells you exactly where the advancing axon front is located. Once the axons have reached the paralyzed cheek and matured, we proceed to stage 2.
Stage 2, the muscle transfer.
Right. We return to the OR. We harvest a free flap of the gracilis muscle from the inner thigh, along with its designated blood vessels and its motor nerve, the obturator nerve. We inset the gracilis muscle into the paralyzed cheek, anchoring it from the zygomatic arch down to the corner of the mouth.
And you hook up the blood supply.
We perform microvascular anastomosis to hook up the blood supply to the facial artery and vein, so the muscle survives. And finally, the most crucial step. We microsurgically sew the obturator nerve of the gracilis muscle to the end of our cross-facial nerve graft.
Let's trace the physiology of what happens when that patient subsequently smiles.
It's amazing. The patient's brain sends a signal down the intact facial nerve on the normal side. The normal side smiles. Simultaneously, that exact same electrical impulse travels down the splice branch, races across the upper lip through the sural nerve graft, enters the obturator nerve, and fires the gracilis muscle in the paralyzed cheek.
So both sides move together.
Yes. The gracilis contracts, pulling the corner of the mouth upward. The patient achieves a symmetrical, emotionally driven, spontaneous smile. It is a true masterpiece of surgical engineering.
To wrap up our reconstructive journey today, let's talk about the intricate cartilage work involved in ear abnormalities. For microtia, the congenital underdevelopment of the external ear, what are the gold standard surgical approaches?
While prosthetic ears exist, autologous reconstruction, building a new ear out of the patient's own tissue, remains the gold standard. but timing is completely governed by biology.
You can't do it on a baby, right?
No, you cannot perform this surgery on a toddler. You must wait until the child has a chest circumference of at least 60 centimeters, usually around age 6 to 8. You need their rib cage to grow large enough so that you can harvest massive blocks of costal cartilage without permanently deforming their chest wall.
There are two main architectural philosophies tested on the boards: the Brent technique and the Nagata technique. Break down the Brent method.
The Brent technique is a methodical four-stage process separated by months of healing. Stage 1 is the heaviest lift. The surgeon harvests blocks of cartilage from the 6th, 7th, and 8th ribs.
And they just carve it.
At a back table, using scalpels and gouges, the surgeon carves these blocks and splices them together with fine wire or suture to create an intricate 3D framework of an ear. They then make a small incision on the side of the head, dissect a very thin subcutaneous pocket of skin, and slip this rigid cartilage framework inside. The skin is sucked down over the cartilage with a vacuum drain to reveal the contours.
But at this stage, it's just a lump on the side of the head. It's not a real ear yet, right?
Right, it has no projection. Stage 2 involves taking the malpositioned native earlobe and transposing it into its correct anatomical position at the bottom of the framework. Stage 3 is the elevation.
Lifting it off the skull.
Yes, the surgeon cuts behind the framework, literally lifting the new ear away from the side of the skull to create the postauricular sulcus. Because you leave a raw surface behind the ear and on the skull, you must cover those defects with a skin graft, usually taken from the groin or the opposite ear.
And the final stage.
Finally, stage 4 involves deepening the conchal bowl and building the tragus, often using a small piece of cartilage borrowed from the normal contralateral ear.
How does the Nagata technique refine this process?
Nagata's philosophy was consolidation. He reduced the process to essentially two main stages. To do this, his cartilage framework is much more complex. He builds a thicker, more robust 3D structure that projects further immediately, intricately wired together with stainless steel.
But if it's bigger, he needs more cartilage.
Exactly. Because he needs more cartilage to build this thicker framework, he waits until the child is older, usually around 10 years of age. In Nagata stage 1, he implants this robust framework and he reconstructs the earlobe and the tragus all at the exact same time, saving the patient several subsequent surgeries. His stage 2 focuses purely on the elevation and skin grafting of the posterior sulcus.
Briefly, what if the ear is fully formed, but it is just sticking out too far? Prominent ear correction or otoplasty. It looks simple, but the biomechanics of cartilage memory are pretty unforgiving, aren't they?
Prominent ears typically stem from two distinct anatomical defects, and you must diagnose which one is present, or if both are. The first defect is an underfolded antihelix.
The inner fold.
Yeah, the ear lacks the defined inner fold, so the upper third of the ear just flops outward. We fix this using Mustard sutures. These are permanent mattress sutures placed through the cartilage designed to forcefully bend the cartilage backward and permanently recreate that antihelical fold.
And the second defect?
The second defect is an excessively deep or hypertrophied conchal bowl. The cup of the ear is just too big, physically pushing the entire ear away from the skull.
How do you pin that back?
To fix this, we use furnace sutures. We place heavy sutures from the conchal cartilage, bite deeply into the tough mastoid fascia covering the skull bone, and physically winch the entire ear closer to the head, reducing the conchal mastoid angle. Often, a perfect otoplasty requires a combination of both Mustard and furnace sutures.
It's amazing how the core principles of plastic surgery echo across the entire body. Whether you are redirecting tension with a Z-plasty and a cleft lip, understanding the growth vectors of a fused cranial suture, or reorienting local tissues for an oculoplastic reconstruction, it all comes down to respecting the anatomy and the vascular supply. I mean, it really makes you wonder if one day tissue engineering will just replace the need for things like rib grafts entirely. Please leave a comment or question for us below on what specific FRCS topic you want us to tackle next. Keep up the active recall, and we'll see you on the next deep dive.